Hi everyone, it is 1 o'clock Eastern time and I would love to get started with our August WonderChat. My name is Missy Hicks. I am the co-founder of Wonders and Worries and the director of the Registered Provider Program and your webinar host. And I'm thrilled that you're here today with us. Just before we get started, we'll do our quick housekeeping before I turn it on to over to our speakers for today. As many of you know, if you've been on here before, you're muted, your audio is off, your video is off, so you'll just see our speakers for today. We're going to use the Q&A feature, so there won't be a chat option during the presentation, but I will monitor the Q&A and either answer you on typing it in or ask our presenters out loud. The recorded webinar will be posted on our website at a later date, so if you certainly want to take a look at it again, you can do that as well. Crystal, if you don't mind, jump into the next. So evaluations, we always appreciate feedback. We look at it, it sort of drives how we move forward with our WonderChat presentations. So when you leave the webinar today, the evaluation will pop up automatically. Would love that feedback. If you miss that pop-up link, you still have another chance. You can, you'll get an email tomorrow just from the platform, and the evaluation will be in there as well. So you only need to complete one, but we would certainly appreciate that. Regarding the PDU process, for listening for professional development is always available at no charge. But if you do need PDUs, you can listen to the webinar, and at the end, there'll be a QR code that'll take you to a place to purchase the post-assessment. You can purchase the post-assessment, it'll be $15. It's $10 per hour of credit. So it'll be $15. You can take that post-assessment, and when you successfully complete it, you'll be emailed your certificate. Next, Crystal. So I just wanted to thank Michelle, Sarah, and Crystal today. They're going to tell you a little bit more about themselves as they speak, but we are excited to talk about ethics in practice today. As clinicians, we know that ethics is a huge important topic for us, and it's sometimes nice just to process it and hear what other people are thinking and how they arrive at decisions. You know, I think sometimes we feel like we're in isolation with the ethical issues and dilemmas, and it's so important to process them out loud. So I appreciate our three presenters today coming forward and actually even being vulnerable about sharing what their experiences were and walking us through those. So I will go ahead and turn it over to Crystal, Sarah, and Michelle to take it away.
Thanks, Missy. And I have to confess a little snafu. I'm not on the right presentation. So I'm going to let Sarah and Michelle introduce themselves really fast while I find the most up-to-date version. And then I'll introduce myself and we'll get started. So if y'all don't mind doing that, that would be great.
Yeah, not a problem. We all make mistakes. So, hi everyone. My name is Sarah Lofton. I am a licensed professional counselor supervisor and a registered play therapy supervisor at Children's Medical Center in Dallas. So I've been here for about 8 years, and I really love my job. But I do a lot of collaborating with other disciplines. For those of you that don't know, play therapy is a counseling modality for younger children where they can use use toys as their words and their natural language of play to communicate and express themselves. They get to choose just what they do in session within limits, of course, but it's been a wonderful intervention for kiddos. It's an evidence-based intervention, and having been here 8 years, it's been really helpful with the kiddos I've worked with. I think play therapy is a really beneficial intervention to have, especially here in the hospital. So that is what I do. What about you, Michelle?
Yeah. Hi, everyone. I'm Michelle Martin. I'm a child life specialist. I've been in the field for, well over 25 years. I'm not going to say the specific number because it will date me greatly. I've been at Wonders and Worries for about 8 years. In that environment, I also supervise the practicum students, and I'm part of the Registered Wonders and Worries provider group as a consultant. So happy to have you all join us today. I'm looking forward to our time together.
Okay, I'm going to try to share this from SharePoint. Give me just a second, you guys. I apologize. Okay. Here we go. Slideshow. Thank y'all for jumping in. Okay, and I'll introduce myself. I'm Crystal Wilkins. I'm a program director and child life specialist at Wonders and Worries. I have been a child life specialist for 18 years now, starting my 19th year this month, which is crazy. I worked for about 12 years in children's hospitals and then have been at Wonders and Worries for the last 6. And I also am a licensed professional counselor and registered play therapist working at Austin Stone Counseling Center here in Austin, and love getting to do both of those roles. So super excited to be with y'all again today. We're going to start off today just to give you kind of an overview of what we're going to cover. Meredith Cooper, one of our co-founders, and I did a presentation back in January that went over in depth ethics and ethical principles. And it was more of kind of the meaty kind of academic version of what ethics is and how it applies to child life practice as well as mental health work. And today is going to be more of the practical. And so Sarah, Michelle, and I each have a case that we're going to share with you that focuses on different ethical principles and how we made an ethical decision related to the care of a client. But before we dive into that, we're going to do a quick review of what we covered in January, just so if y'all didn't tune in, then you at least have a base foundation of what we're talking about. And then we'll dive into the cases. And I hope that y'all will enjoy hearing that and can apply it to your own cases, right? As you think about your own patients that you're working with, if you're in the hospital setting, or clients that you work with, no matter what setting you're in. And so these are some of the core ethical principles that most likely, regardless of what discipline you are, if you're a child life specialist, if you're a licensed professional counselor, social worker, chaplain, whatever discipline you're in, most likely these 5 principles apply to the work that you're doing. And so we'll do a quick little overview. Autonomy is respect for independence and self-determination. So when we're working with clients, when we're working with families, we want to give them opportunities for choice, opportunities for control, as much as feasible. Justice, when I think of justice, a lot of times I think of equality and fairness, but it's really more about giving the client what they need. And so for a client that is Spanish speaking primarily, making sure that you have clinicians within your practice that can speak Spanish, or if you have a client that is blind, being able to have materials in Braille for them to be able to receive information, education, whatever you're offering to them in a way that is feasible for them. And so it's not necessarily always every client gets the same thing, it's the clients get the thing that they need. So these next 2 words, Sarah and Michelle and I have joked about, we don't really know how to say them. And so I say beneficence and non-maleficence, but I don't know that that's right. And so tomato, tomato, you get to choose how you're going to say it. But beneficence is that we seek the welfare of our client. We seek what is good for them. And that can get really tricky when we think about there's a lot of good, right? Like there's a lot of different ways of viewing what good is. And so that it's not super black and white in determining that. Non-malfeasance or non-maleficence, however you want to say it, is doing no harm. And so we want to, as best as we can, prevent risk and to, again, do what is good for the client. And then fidelity, loyalty, or honoring our commitments. We want to make sure that we're being faithful to what we say that we're going to do as clinicians. So those are some of the key principles that as we go through these different cases that we'll refer back to. And so you can think about that as well if you have a client that you're thinking about, the reason that you signed up. You're like, oh, I want to make sure that I'm doing what's the best thing. Think about these ethical principles and which ones apply to the clients that you're working with. This is a quick review of the ethical decision-making model. Essentially, ethical decision-making is promoting the best good. Obviously, if we had a formula for every client that we work with, we'd run the formula. But we work with humans with very complex, complicated situations, and it's not cookie cutter. No case is the same. Even if you're working with siblings, every sibling is so unique. beautifully unique, that they're going to experience the same situation, the same circumstance in a uniquely different way. And so promoting the best good for one client may mean something completely different for another. And so we have to really think through all the different variables, both internally and externally for the client as we're making decisions alongside them. And again, at the heart of ethical decision making is advocacy for the clients and weeding out competing variables, making sure that you're really focused on who the client is, what they need from you, and with you. And so these are some key questions to ask yourself if you're in a situation where you're like, oh, I don't know what to do, which is usually, that's what goes through my head when I'm like, I think this is an ethical issue, is, oh, I don't know what to do. But it's, what is the issue at hand? Why do I have that icky feeling in my tummy? What foundational principles are at play here? And what options are present that uphold my professional ethics and are supportive for the client? And so those are the kind of questions that I would encourage you to think through as you think of the cases that come to mind as we walk through these. All right, so I'm gonna kick off Sarah here. Sarah's gonna be our brave first go, and she's gonna share a case from her work. And then we'll come back together at the end when she's done kind of sharing. Michelle and I will pop back on and unmute and may ask some more questions, or if y'all are putting some questions into the Q&A feature, then Missy will feed those to her to be able to respond to. But Sarah, have at it.
Thanks, Crystal. Yeah, whenever we were talking about just cases that would be helpful to discuss, this is actually the very first one that I thought of. This happened earlier on in my career and was very challenging and has stuck with me for years. So this was a 7-year-old female that was diagnosed with aplastic anemia. So she was an only child within a Spanish-speaking family. I speak Spanish as well, so that's really helpful for the families that I work with here at Children's in Dallas. So this kiddo had received a stem cell transplant and it was not successful. She had relapsed. She had multiple prolonged hospitalizations. You know, she was referred to me for poor coping and just being here for so long. So I provided individual play therapy with her at her bedside and also regular parent consultations. So just talking with mom about ways to help her coping, ways to provide her with choices to give her more power and control, help her be as independent as possible. Because we know developmentally for that age that that's definitely something that is important. So that was my work with her. So I worked with her probably 2 to 3 times weekly while she was here. And of course, collaborated with lots of other disciplines, child life, of course, and social work with the medical team as well. So the ethical dilemma presented itself one day when I was at work and the medical team called me up. We knew at this point that the patient was terminal, that there were no other curative options for her. And the team knew that she could go home and likely have an improved quality of life at home, per the team's thought. And so they really wanted me to talk to the patient, let her know about her prognosis, because she hadn't been informed directly yet. And they also wanted the team wanted the mom to understand, because in the team's eyes, the mom was in denial and wasn't really understanding the prognosis and what this meant for the patient and the family. And so the team knew that I was involved and really wanted me to play a part in informing the family of that information, which I'm sure some of you are like gasping right now hearing that, because I did as well when they first called me up to ask me to do that. You can go ahead and go to the next slide, Crystal. So the ethical principles at play, I'm sure you guys off the bat thought of non-maleficence and beneficence for sure. So this actually comes up quite a bit working in the hospital setting where a child may have a terminal diagnosis, terminal prognosis, yet parents do not want to inform the child of that diagnosis because they don't want the child to lose hope. That actually happens quite a bit with families I've worked with. And I know, Crystal, when you were talking about ethical principles and thinking about your client, that's a big ethical challenge in working with children, as it's not just the client, it's the whole family, because parents really have a say in the information that children receive. So a lot of families I've worked with, parents have wanted to share with the child, other parents haven't wanted to share with the child what would happen, and we've had to really honor that for them. So I thought a lot about, am I doing the child or the family harm in following through and doing what the medical team wants me to do and telling the child about her prognosis? Would I be promoting good and doing that as well? And then autonomy played a huge role in this too, because would I be taking autonomy away from mom in this case by taking over and telling the child what the team really wanted me to do? Which, keep in mind that the team thought this was best for the patient. In no way was this a negative approach, or did they have bad intentions. They knew in their minds that the child would really feel better at home. So I asked myself a lot of questions in this case, for sure. So my first question was, is this the patient's need? Is this what the patient really needs in this moment? Or is this more a need that the medical team has? That was my very first question that I asked myself, is who is this for? And then right away I thought of, who else can I talk to about this? Because this was a really heavy thing to take on as myself early on in my career. And so I really wanted to bring in other people to help me make this decision. And not only to help me make a decision, but who can I collaborate with and who can come with me to speak with the family if that's what we choose to do. My very first thought, which you guys might have thought of this as well, is this is a big role of child life to be interpreters for medical teams and to help children understand their diagnosis and their prognosis. So I, of course, called the child life specialist right away, and we talked through this. I was really close with the family, and that happens a lot with Spanish-speaking families that I work with, that I do become a closer part of their team because of that language barrier with other providers. But yes, Child Life and I talked at length about this case and this family. And then what will benefit the patient or the family most? So again, going to non-maleficence and beneficence, what will be the most helpful, and not from my perspective and not from the medical team's perspective, but from the patient's perspective and the family's perspective, what would be best for them? So I had several options. I could just deny the request and say, listen, which a lot of people would have done this, I think. This really isn't my job. This is, not in my role or in my realm of what I would do. I could have just educated them on the role of psychology, what we do with families and with patients, and just left it at that. I could have also just said, "Ooh, child life, this is your area, defer, which I definitely thought about. And then another option would have been to collaborate with other disciplines, talk with mom about what she wants and what she thinks is best for her and her child, and figure out collaboratively with other teams, psychosocial and medical, and the family of what would be best. So I consulted and collaborated quite a bit with this case. That's actually one thing I really love about being in the hospital setting is, I love the collaboration piece. So I love that we aren't the last line of defense for families, that we can actually collaborate with other people, figure things out, to see what's best.
Sarah, I'm so sorry to interrupt, but I think your video might be frozen. Do you mind just turning your video off and on and see if that helps?
Or what were y'all able to hear everything?
Totally can hear you, yes.
Oh, good. You know what? I am cursed with technology that my face always freezes on the worst possible. Let me see if I can.
You look lovely.
Yes, you do.
Sorry, guys. How's that?
We don't see you.
Well, I think the most important thing is that you guys can hear me. So is it all right if I go ahead? Okay, I see head nods. Perfect. Just imagine my beautiful face as you hear my voice, everyone. Okay, so a big thing that I did, like I mentioned, is consult and collaborate with a lot of people. As I was saying, I really love being in the hospital setting and being able to do that and it being expected. That's actually one of my favorite things about being here in the hospital. So I first contacted, whenever we were preparing this, I made a joke that everyone should have a work wife or a work husband. You should have a best friend at work that you can really talk to, especially about these ethical dilemmas, that will not bring judgment to the table, that will be understanding and will speak with you honestly about these cases. And so I have that here at Children's. And so that's the first person I spoke to. I said I had this really challenging request from the medical team, and I let her know all about it. And she, of course, was wonderful and reflected and was really helpful. And I do really well with someone when I can just talk things out. And so that's what she helped me with. She helped me talk through all of these questions that I had, speaking about the ethical principles, talking about what would be best for the family. And then I also talked to, of course, Child Life was my next phone call. And they were aware of the situation as well. We had, of course, been talking the whole time, working with this family together. And they, they said, honestly, I do feel like the patient, I don't know how many of you have worked with patients with terminal illnesses, but sometimes, Crystal and I have talked about this before, that sometimes the patients can really tell. Kids know that something is up and something's amiss, and it can be really helpful to educate them and let them know what's going on. It can honestly put them at ease sometimes to understand a little better about what's happening. So the child life specialist in this instance said, I do feel like it would be helpful, but of course I want to defer to the family and what they think. And so the child life specialist really helped me see where the medical team was coming from as well, that they were all had the best interests of the family in mind. And then, of course, we spoke with social work. Social work works a lot with the parents here at the hospital. And so we really wanted to see how mom was feeling. And so we did a lot of collaboration and discussion together. And then we decided to speak with the mom about it. You can go ahead and go to the next slide, Crystal. So with all of this questioning and all of this talking with other people, we decided, because the patient really knows that something is up, we just wanted to talk with the family. So we did, we sat down, it was myself and Child Life, and I think social work was there for part of the discussion, and we just talked to mom about everything that was going on. I don't know if you guys remember, but I had mentioned that the medical team thought that the family was in denial and really didn't want to believe that what was happening to their child was happening, which of course we know even that is a form of coping and would be understandable. But with talking with the mom, I didn't even mention any of that. And she just said, I know what's happening to her. I just have hope that there's a higher power and that the doctors aren't the end all, be all of what will happen to my child. And I believe that God will heal her. So the spirituality presented as denial to the team. So it was good for me to be able to talk to her and talk to her about her coping and how she is working through all of this. So we just talked to her about the child and her understanding of what was going on. And the mom herself came to the conclusion, I really do want the child to know. I want her to know what's happening and what is going to happen. So she decided she wanted to do it that day. And she said, but I want you guys with me as support. And so, you know, I'm a big fan of not having a lot of people come into a patient's room. But myself, Child Life, social work did not come in. Myself and Child Life came in with mom, and the patient right away said, what's going on? What's wrong? You know, you guys seem weird. And we just said, hey, we just came to talk to you, and mom wanted to chat with you. And she said, I want everybody out except for mom and Sarah. And so we stayed, and then mom understandably became pretty upset and asked me to tell the patient. When I got into work that day, I did not think that this is what I would be doing for sure. So I did. I ended up telling the patient what was happening in a developmentally appropriate way, that there was no other treatment that she could have. And she, of course, cried. She and mom cried and held each other on the bed. And it was a really challenging case. It was really challenging. You know, so I feel like there were a lot of other players that were impacted by this family. Of course, the other supportive services, everyone that was involved knew what was happening and knew about it. With the whole evaluation, is there anything that I would do differently? I don't think so. I think maybe one thing that I would have added is just that education piece for the medical team. Because I was earlier on in my career, I didn't really feel comfortable advocating for my role and talking about my role, but I do wish kind of at the beginning I would have said, you know, hey, this really isn't typically something we do, but I am a team player. Let's talk through it. So I do wish that I would have educated them a little bit more about psychology and what we do. How has this influenced my practice? Oh, self-care, you guys. I just, as you can see, I'm still affected by this case. So early on, I learned to find your work life and to engage in a lot of self-care. And so that is what I did, especially after this case. And also that the people around you may not completely understand what you do, like in your personal life. And so just the importance of having those people at work too, who do what you do and can talk about it with you. And then what did I learn? So I talked about self-care. I learned that my job is challenging and that there are, you know, Crystal and I have talked in the past, with Michelle too, just about why do we do what we do? Our jobs are hard. But, you know, I think we have a passion for it and we love what we do. And so I learned early on that my job was challenging, but that I also found my dream job so early on and so young. So that is definitely what I learned, especially with this case as well. I'm thankful for a lot of things in working with this child and this family. I'm for sure thankful for just the collaboration piece, and thankful for, you know, because Child Life could have said, hey, stay in your lane, this is my job. But I think we knew working together kind of that you can't approach a family with a cookie cutter approach, that you can't just do the same thing for every family. And I think that this was really helpful in helping me learn that as well. I'm thankful for the collaboration with other providers and what I can learn from other providers as well. And I know the video is choppy, so I'm sorry guys, but I'm just glad that y'all can hear my voice. So I'm also thankful for just the resilience and hope that I've learned about working with this family, and that there will be challenging situations, but that boundaries are so important as well. And just kind of figuring out that work-life balance and ways to keep work at work, but knowing that the kids that you work with will also impact you outside of work and what to do with that. So yeah, whew, this is a heavy case to start with, you guys. I'm really sorry about that. But it was an important case.
Thank you for sharing it, Sarah. I know it can be tough to kind of go back, especially this was one of, I remember I was working at Children's with you when you had this kiddo, and you were an intern. And so this is a doozy of a case to have so early on in your career. So I appreciate you going back and being reflective and thinking through all the different things, because I know that in some ways it can be painful to revisit because it was so hard, but you did a great job sharing. And it brought me back, like I can remember a case in particular where just that dichotomy, I think sometimes with the medical team, where they do view sometimes that hope piece as denial. And I think so often that comes from they're trying to do their job, like, and they're trying to make sure, have I explained it well enough? Have I explained it well enough to where the mom understands? And so sometimes it can feel like beating a drum, you know, and the parents are like, I get it. Like, I'm just trying to have hope here. I'm trying to hold on to my faith too. And so that can be such a tricky place to be. And you're in the middle, you're in the messy middle of trying to validate both places. And so it sounds like you did a beautiful job. I don't know, Michelle, do you have any questions that pop to your mind? I know I have one, but I'll let you go first.
Yeah, sure. Thank you. Sarah, thank you for sharing your story. And it's hard sometimes to reprocess these things. I'm wondering, could you speak to options the family was given about sending her home, giving her the option to remain in the hospital or go to a hospice center? Was that part of the planning?
Yeah, that's a great question. Definitely. I think with each family that I've worked with where this is the case, the team really does try to figure out what is best for the family and what is best for the patient. I think in their mind, they really wanted the patient home just because they thought that would be best for her. But yes, so they did offer lots of options, and social work was really involved as well, and just helping them figure out what was best for the family. And they, to tell you a happy ending, they did end up going home, and this patient is still alive. So they beat all the odds. And so the mom was right. So yeah, it's a really, which is another reason that this case sticks with me so well. And so it's such a prominent case for me. So it's a happy ending for sure.
Sarah, I do have a question that came through on the platform from Bindi. And Bindi said that she had lost sound when you were talking about like what you did. And she was wondering if you use play therapy within your intervention.
Great question. Yeah, I did. So I brought a bedside kit, which I have several in my office right now, but I created a bedside play kit for the patient, and I would take it and see her in her hospital room at her bedside. So I saw her 2 to 3 times a week for about 30-minute sessions. Play therapy within the hospital setting is definitely trickier. I've done full presentations on that. So it is harder with confidentiality and people coming in and out, but that's what I found to be the most helpful is 2 to 3 times a week for 30 minutes at a time. And it would be individual with her. Sometimes mom would be involved, but more frequently I would meet with her individually, and then I meet with mom individually at other times for those parent consultations. Good question.
Awesome. Missy, were there any others that came in through the feed?
None at the moment. So thank you for answering that though, Sarah.
Awesome. Sarah, I feel like you kind of answered mine too. My question is just kind of reflecting back and thinking of some of the professionals that might be newer of, is there anything that you would tell like a brand new grad that gets thrown into a similar situation? You've already talked about self-care and some of the things to do, but anything else you would say to a new mental health professional or
I feel like, and when I take on interns as well here at the hospital, you know, I always say like, be honest with your feelings, because that's one thing that I loved about the person that I collaborated with here at the hospital was that, you know, I came into her office crying, and she wasn't like, "Whoa, this isn't for you." You know, you do not need to be here. She was very understanding, and that we're humans too. And although we do something really challenging, you know, we still do a good job at it, and we're still humans. And so it's understandable that we'd be impacted. I think the hardest thing is if we just push it down, push it down, push it down. And then what if it comes out during a session with a kiddo, you know, which could have a harder, more challenging impact on the child and family. So I think, you know, what we tell our clients to do, be in touch with your own emotions and how the families that you're working with impacts you as a person as well, and working through those is the first and most prominent thing that pops up for me, Crystal.
Yeah, I think that's the only way you sustain in this field, is if you remain reflective, and if you, it's the only way to keep your heart, I think. And yet sometimes that is really vulnerable, and I'm so thankful you had somebody that you could process with that let you have that. And so that may or may not always be possible, depending on the work environment that you're in. So I'm thankful you had it. Okay, anything else, Michelle? Oh, sorry.
Crystal, actually, Sarah, I do have a follow-up from Bindy's question, a little more clarifying about the play therapy. I think she was kind of wondering if you use specific play therapy when your intent was to help the child understand her prognosis.
Oh, okay, I see that question. No, actually, it was not. So sometimes I encourage, that's a really great question. So I do more non-directive play therapy with children. So I do child-centered play therapy here at the hospital. And so she was 7, so we were able to just talk about it, and because she also understood that something was amiss and something was up, so she, I think, already knew. And so we just gave her words to what she was thinking and feeling. That is a really good question. So something that I do teach, which was first published by Sue Bratton, is structured doll play, which I know that Child Life does a lot of that as well. But so that is also what I teach parents to do at times when they need to give information, or when they need to help a child prepare for something, for a change, or something that might be happening at home or in the hospital. But I did not do play therapy when we gave her the information. I also wasn't expecting to give her the information. I was just there for support for mom. It was mom's plan to tell her. Mom wanted to tell her directly, just did not go as planned. Got to be flexible. But yeah, great question.
Thanks, Sarah. All right, any last minute thoughts, and then we'll shift gears. And if more questions come in, certainly Sarah can answer more towards the end.
Crystal, I'm sorry, I just have one more comment that I want to share. People can look at it in their in the Q&A, but Helen said, not a question, but a comment. I think it's a great example of the importance of a multidisciplinary team approach. Having families connect with someone on the team can be an excellent support for them, promote a positive experience, and can also ensure someone is communicating the family's needs to the team in general. So thank you for tying a bow around that, Helen, for us.
Yeah, Helen, that is so true. I mean, I've worked with so many families where social work has really connected with the family, and social work has been the family's person. And then I've worked with some where Child Life is the family's person. And what I love about the teams that I work with here at the hospital is everyone is so family focused that we don't care who the person is, as long as the family has connected with a person and feels comfortable with that person to be able to tell them, you know, concerns or problems that they're having. So yeah, Helen, that's a really good point.
Okay, I will move on to my case. I'm going to share with you guys a little bit about a client that I worked with. And most of y'all, if you've tuned in to WonderChats before, you know me as my Wonders and Worries person, child life specialist. But this is actually a case from my other job, which is a private practice counseling role. And so I was playing licensed professional counselor and registered play therapist with this kiddo. So if you're wondering about my role. But this 9-year-old came to me in the middle of COVID last fall. And he has a complex cardiac history, had multiple surgeries when he was a baby, and had another surgery when he was young preschool age. He doesn't remember a lot of those, but he does have pretty significant medical anxiety, and going to the doctor is hard. And yet he has routine follow-ups, as you can imagine, with that complex history. His parents are married. He has a young adult sister and a toddler brother. I don't exactly know why I included this, but Dad is in law enforcement, and he had a previous diagnosis of PTSD. And I think why I put it in here is just this family was very open to mental health support, and that was something he had already worked through his own complex diagnosis and really wanted support for his kiddo, which was really cool to see. And so Mom initiated support for this child in the middle of COVID because he had been doing homeschool. And we were starting to open up a little bit more here in Austin, and he had the option to go back to school, but because his anxiety was so high, he was refusing. And Mom was really concerned about the level of anxiety that he had with social interactions, and even with doing like play dates and things like that with kids in his neighborhood. That was something that was tricky and anxiety producing. And she noticed also just a more prominent depressed mood that was not characteristic for him. And so that was why she initiated counseling support for him. And so we engaged, we were all virtual at the time. And so with 9 years old, I figured we could do virtual support and have some planned activities for him. So it was definitely more on the directive side. And so similar to Sarah, I operate, I would say I'm more prescriptive with the extensive history that I have as a child life specialist. I'm very comfortable being directive in some of the activities that I do and present with children. But I also love and value non-directive play as well. And for his age, I did feel like he could do more activity-based therapy, expressive arts, that sort of thing. But how the ethical dilemma presented itself was that he wasn't responding very well to that. He would come on screen, and he also had ADHD, so that definitely impacted it, but he was all over the place. It was hard to get him to stay on screen. He would jump around the room, and I'd be like, hey man, I need you to come back on screen. And you could see his need for control. There was one session that I did with him where he was like, before I said anything, he was like, today I'm in charge. And he started telling me the story and playing few things, which was great. It was a beautiful kind of example of non-directive play, even on a virtual format. And so I just kind of followed him, but it was very hard to follow him because I couldn't see everything that I wanted to see. I couldn't hear everything that I wanted to hear. And so when he said that in one particular session, spidey senses go up, and I'm like, I wonder if he needs the full playroom, and he needs non-directive is something that would be really valuable to him. And so I hung with him a little bit longer and had made suggestions to the mom. I was starting a CPRT group, child parent relationship therapy group, and was starting one of those. And so I had suggested, hey, it might be really valuable for you to jump into this group because then you could learn some of these strategies that I'm doing with him. And then you could do that at home with him, figuring that depending on how long we were still doing mostly virtual, that might be an option. But she didn't jump into that. And sweet mom, she was homeschooling him, has a toddler, doing all the other things. I can imagine adding a group to that didn't make sense. But I was feeling kind of stuck of not really knowing what to do with this kiddo. And so that's the ethical dilemma. So the issues at play were autonomy. Certainly I wanted to be able to give options to the mom. Oh, I should back up, sorry. There was another session where, again, he was kind of all over the place, and I was trying to get him to come back on screen, and at some point he like literally slammed the computer screen down. He just went like that, and then pulled it back up and was like, ha, 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 I'm just kidding. And I was like, oh, Fed, it seems like you're mad. It seems like you're really mad. And he diverted and went to something else. But it was at that point where I started questioning am I doing harm? Am I doing harm by continuing with him in this virtual format and not giving him the full playroom to be able, but then the issue of but not having sessions, is he then going to be in a worse situation? And so the ethical principles at play, autonomy, I wanted to be able to give mom choices in terms of what his therapy looked like. I wanted to do good. I wanted him to get better. I wanted him to feel in control. I didn't want to cause harm. And then I wanted to be faithful. Like I had taken them on as a client, said that I could be supportive. But then with the circumstances as they were, it was really hard to see an option that met all of those things. Some specific questions that I was asking myself, is virtual directive play therapy working? What evidence do I see for that? Is virtual directive play therapy harmful? What evidence do I see for that? Would child-parent relationship therapy work more effectively? And when will direct in-person sessions be an option? And so those were all the questions that I kind of thought through. And this was at a time, I can't remember the timeline exactly, but I think cases were increasing again, so it didn't seem like the right time to come in session. And I was also, a lot of the kids that I was seeing at the time in person that I had gotten exception cases for, they were teenagers, so they weren't playing with all of the toys. We didn't have a policy yet set up for how we were going to clean and disinfect all of that. And so it was early still to be able to shift in that direction. But the options that were available: continue virtual, offer CPRT, or discontinue services until direct services were an option. The person that I collaborated with was mom. And then eventually, I didn't put this on there, but my boss, I asked permission to be able to see him in person. And so, let's see, what else to share? Yeah, so those are the options available. What ended up happening, again, mom couldn't do CPRT. That didn't work for her. Once we got to that place where he slammed the computer shut, I said, I think we need to do one more session just so that he knows he's not in trouble, that we're just going to take a break until we can come together in person. And then I'll let you know as soon as I can. And so we did a final session with him, and he was so sweet. You know, I was like, it seemed like you were really mad last time, and I think this is really hard. And he was like, yeah, it is. Like, I just don't like the computer. And he's like, I like computers for games, but I don't like, this is really hard to talk about things in this way. And I was like, I get it. It's okay. This is only good if it's good for you. And so we made a plan to discontinue for a little while with support to mom, where she could do parent consultations as needed if things came up, or if she chose and wanted to do CPRT even individually, we could do that. And then it was about a month, and was able to then kind of get things set up to where he was able to come back in for in-person sessions, and I'm seeing him now. And it's been very validating to see as he's using the whole playroom, how much more he's able to express, how much more I'm able to see as a clinician and hear, to be able to support him more effectively. And it's been great timing because he did have to have a recent procedure. And so it's been good to be able to prep him for things and just be a safe space for him to process through the feelings that are coming up for him related to that. Yeah, so I just kind of shared with you the outcome. Is there anything I'd do differently? I think the only thing that I probably would have done differently was when I invited mom to participate in the CPRT group, I think I would have put an exclamation point behind it. I think I would have highlighted how important it was because of what I was seeing in sessions, and that I didn't feel like what was happening was sufficient. And so I think if I had to do it again, I would have really tried to see if she could make it work in any way possible. And because I think those skills would be valuable to her ongoingly for her in her relationship with her son. What did I learn? I think it was really helpful just to think through, especially so many of us have shifted to virtual support. And it's worked, right? Like it's worked in different ways and it's been valuable in different ways. But I also think it's not everything and it doesn't work for everyone. And so being able to think through what kids need, the full direct human contact, and especially I think as we're trying to get back to a new normal, I think that's important for us as clinicians to think about. And then what am I thankful for with this client? One, I'm thankful he was able to express himself, you know, as much as I didn't like all of a sudden the computer screen going blank and all of that. Like, I'm thankful that he found a way to let me know he was having a hard time. I'm thankful for the flexibility of the mom, and being able to work with kind of a start-stop thing. Yeah, I'm thankful for the timing that it worked out that I was able to see him in person. So there's a lot of things I'm thankful for. I'm thankful I work on a team where I could easily collaborate. I could go to my boss at any point and say like, hey, like I'm struggling. I don't know how to serve this kid well, and know that he would advocate for that. Yeah, so there's a lot of things I'm thankful for. But I'll pause there and see if Sarah or Michelle have questions for me, or Missy if any came in.
Thanks, Crystal. Thanks for sharing your case too. The one thing that popped up for me with your case was the anger piece, because we know, right, we know that kids express anger all the time in child-directed sessions as well. But how do you think this anger differed from like a typical expression of anger in a session, whereas that wouldn't be non-maleficence, right? Because that's what you kind of were talking about, is you could tell with the child's anger, like, oh, are virtual sessions kind of doing more harm? Like, how did your clinical judgment play in, and how did you see that as different?
Yeah, that's a really good question. I think the main difference for me came in like when he would express anger through play, it was through like his action figures, through different things like that, to where it wasn't necessarily directed at me or anything like that. It was just anger because he was playing it through with other characters. And so the fact that he was looking at me and slammed the thing, it was like, I'm after, like, it was that, I think, which of course kids do that too in play sessions, and you set the limits and all of that, that you would have like, hey, I'm not for shooting with the Nerf gun, or hey, I'm not the bop bag, but you can go punch the bop bag. You know, you can do that and set that limit. But the fact that it was directed at me, I had very little control. I couldn't control whether, or even set a limit. I could say like, hey, the screen is not thrown down, but it did feel like almost like a cry for help in some ways, of like, this is not working for me.
Well, it almost seems like because it's the delivery of the intervention, right? The virtual piece. It kind of makes me think if he were in a playroom and most of the toys were broken, right? And so then he's constantly frustrated because all the toys are broken. Like, how's he supposed to himself? He can't play with any of the toys. I'm always on board for a couple, you know, that happens, they break, but I could imagine that being frustrating for a kid. And so that's frustrating for him to do.
Yeah, or for like a really young child to be brought into a room with just couches, right? Like for it not to be a place for them. That would be super frustrating. Yeah. So it's a good analogy.
Virtual sessions, the good, the bad, and the ugly.
Yeah, they just don't work for everyone, you know. It's that, I think, important gut check for all of us, is that it can be convenient in many ways. It can be helpful for some if they can't get to you, but it's not necessarily going to give you everything that you want or the child needs.
I think that's a presentation in and of itself, right? Ethical dilemmas with virtual sessions. That could take.
Maybe we should do it, Sarah. Michelle, how about you? Do you have any questions for me?
Yeah, my question is more related to transitioning from a virtual world into an in-person world. Did you find that you needed to reset your relationship with him, so to speak? Like, how did you make that transition? Because it's very different, and so many of us are slowly doing that, right? Like moving from virtual to in person. Can you
Yeah.
speak to that?
Sure. Yeah. No. Thank you for that. So I did a parent consult with the mom beforehand and kind of shared with her how to prep him for coming back into session, just letting him know, hey, we heard back from Crystal. The full playroom is open now, and so we're going to go to this place, and this is what it's going to be like. And so just to kind of help prep him verbally before he got there. And then I met him at the car. Like I go out and I get my kids because the doors are locked in the building that I am in here. And so I went and got him at the car. And so we had the walk to the playroom, which was nice. So like me just being able to come and be like, oh, it's so good to see you. I know it was hard those last couple sessions that we had. And so just be able to validate what his experience was and just said, I hope that this is going to feel different for you. I hope that when you see the playroom, that you like it, that you have the toys that you need to be able to feel comfortable. And so we had that long walk to the playroom. And then once we got in there, I did very much like I would on a first session of like, here's the playroom, these are all the toys that we've got. I have expressive arts and games too. And so I'll let you explore a little bit and then you can let me know what you'd like to do. And so just gave him a lot of that freedom. And then it was really cute on the way out, the very first session, I remember, he was walking out and he's like, this is better. Like, and he was just like, yeah, good job, thanks. And you could just see relief. And he just said, like, it's hard to talk about stuff. And I was like, yeah, it is. It really is. And you're 9 and you need the toys. And it's my job to pay attention to that. So thank you for telling me.
Perfect. Thank you. I like the walk to the playroom. I miss that because so much processing and so much connection can happen in the walk. Yeah.
It's a therapeutic walk.
Huge.
It's not just
It
a walk.
is. Yeah, it's not passive. It can be very active. And yeah, I love that you all were able to reset and
Me too.
add a relationship, but added to the relationship. So perfect.
Sure. Thanks for asking.
Yeah.
Anything else, Missy, coming through? Or are you good?
Actually, one just came in. I've been in person during the pandemic. Do you feel that virtual CCLS services have been beneficial for certain populations and diagnoses more than others? So virtual services better for certain populations or diagnoses than others.
Yeah, I can say just from talking with our team here at the Stone, we've noticed a trend and there's more men signing up for counseling. This is, we see adults too here. There's more men signing up, so certainly that. But as far as kiddos go, I think it's helpful at Wonders and Worries and the Stone. I think if families live really far out, like if there's a huge distance, that makes getting in person difficult, then that has opened it up to where clients don't have that deterrent. And so virtual support can be really valuable for that. And I think for teenagers who tend to be very social and have a lot of extracurricular sessions, Sarah's back, we see your face. But I think for teenagers, it can be helpful. But again, it depends on the teenager. Are they able to engage in more kind of talk-based or technology supportive activities? Can they do that? And so, Michelle or Sarah, would y'all have anything else to add to that?
I 100% agree about middle schoolers and teens. Like it really fits their style because in general, so much of their world is around computers. So they seem to appreciate it the most. It is trickier the younger you go trying to do virtual support, but definitely spot on for middle school, high school.
Yeah, so I work with a lot of the little bitties here at the hospital, and I also have been in person during the pandemic for the most part. So I do have one day a week where I see a lot of virtual patients. So I will say that I've had much more parent involvement than ever before. So typically I try to see parents every 3 to 4 sessions to talk about progress and progress at home and during sessions, and to teach skills that they can use with their children. And I feel like sometimes I'm chasing parents down, like, you know, a lot of families say like, here, just fix the child. But parents are so involved with their child's lives, understandably. And so I haven't had to chase parents down as much. Parents are very comfortable with taking a week off from bringing their kid in and being able to meet virtually. So I've had more parent involvement. And I know that your question was specifically about diagnoses. I haven't seen a difference in diagnosis and if they're better to work with virtually or not. So that is a good question, but I haven't seen a difference. But yes, if virtual or in person, I will pick in person every time, especially for a younger child, for sure. But I've met with all of my parents virtually, which has been really nice.
Yeah, we've definitely seen an uptick in the number of parent consultations that we've done. Just the typical, like we're meeting with families a lot more frequently and collectively as a team. So, okay. All right, Ella, for time's sake, especially too, I want to make sure that we give Michelle her time. And so I'm going to pass the baton to you.
Okay, thank you. All right, so I worked with this client early in my time with Wonders and Worries. So like Sarah, kind of new in a different way. I was new to Wonders and Worries and not necessarily as a child life specialist, but Vanessa was about 11 when I started working with her. She was in 6th grade. Her father was incarcerated. At the time, she lived with her mom, her stepdad, and then other family members. I did not know what Dad was incarcerated for, neither did Vanessa, and she was told that she would be told once he was released from jail. I think age was in that factor, her being older than 11, that they expected his time would be up, she would be older, she could handle the information. She told me, no matter what it was, that she would love her dad. He had stage 4 cancer. He, at the time when I did the intake with the mom, he had 6 to 12 months to live. He would be hospitalized several times. He would go for chemo at the hospital, get treatment, and be transferred back to the detention center. He did have the hospitalizations. There wasn't the opportunity to visit him in the hospital. The distance between where they live and where Dad was too vast. And I imagine these were like last minute hospitalizations. And I can't imagine what the rules would have been around that. So she may not have even been able to have gone to the hospital to see him. So this was many years ago and COVID wasn't a factor and she would have been old enough, but just thinking, given his own situation, I'm sure there was a guard and whatnot. So I don't know what the hospital would have said about that, or even the guard, or whatever the correct title is. So, and she and I worked together for over a year. We did 7 individual sessions, and she did attend the teen group once. To put that into perspective, for Wonders and Worries, typically we do 6 sessions initially, and they tend to be weekly. Of course, there's flexibility in that, right? We start with that and then do sessions as needed, especially related to end of life and then bereavement. So just that number alone, 8, is low. It's one of the things that when I go back and just refresh my memory about this situation, I don't like that number. It needs to be higher. We could have done so much more, and that still sits with me. So it was tricky to go back and read through her story and recognize that. So we did focus on medical education. We worked on expression of feelings and then some coping strategies. During that time with her, she, typical sixth grader, she had good friends, she was in dance, she was busy. The teen group was a good fit for her. She enjoyed the activity. I believe they went to iFly and then Amy's Ice Cream. How could that not have been awesome, right? So she didn't do any of the other teen groups that were offered to her, and that could have been even more therapeutic and another layer of support for her. During my time with her, so many other things happened. She lost a friend to suicide, and in quotations, you say it was witnessed. Unfortunately, it was witnessed by many. And just, I, even to this day, it hurts my heart to think about how traumatic that was for her. There was a question about whether or not the girl intended to do so on purpose, but regardless, the harm had already happened. So at her young age, CPS was involved, not for her directly, but for another friend. Another friend had attempted suicide and was stopped. She had yet another friend who would cut herself, and obviously a cry for help, right? But for Vanessa, one of her biggest things in relation to that part of her world was that no one listened to her friend. She really had issues with those adults around them that weren't doing what was needed. They weren't supporting those that were really struggling. So, any one of those is a giant stressor. But for this young lady, she had many things happening over and over and over again. We, in the process of working with this family, thinking about Dad's diagnosis, I did reach out to staff at the jail. I forget the specific title, but in the hospital, it would be equal to a social worker. I could not connect with him. I emailed him. I had permission from Mom. I attached the authorization of release and, explained my role and why I was reaching out to him. I called, left that brief little phone message to help him understand why it was I was reaching out and why it was so important. It never happened. So for me, that's kind of a hole, right? Like there was so much more that I think could have happened just to even understand what was going on, and then relay that information to Vanessa, either relay it or make sure that she understood what was going on with her dad. He was diagnosed and hospitalized in 2013, August 2013, and then he died in March of 2014. She was able to go to the jail. There were plans for her to see her dad. It really was an end-of-life situation. All the arrangements were made. Mom and Vanessa traveled to go see Dad. They were there at the jail, and then they were told, no, you cannot come in. And just awful, right? Like, one, I'm sure she had to get herself ready to put herself in that position to see her dad after not seeing him for such a long time. We did talk about physical changes, so she knew in some way that he would look very different, and I did try to describe as much as I knew how he would look different. In the hospital, we would take a picture and work in the lobby together and talk about what she would see and how Dad looks different. I didn't have that opportunity, so again, minimal information. So one, preparing her. Two, the long drive, her own need and her mom's need to prepare themselves for that, to be so strong, and then to be told no. Again, it just breaks my heart. It could have been handled better, right? She was able to be there after her father died. That was when she saw him. She reports he looked so different, very thin. not the dad she remembered. In attendance at the funeral was just her and her mom. No one else was there. And the inmates at the jail were the ones who buried her father. So just layer upon layer of just challenges, right? This young girl, and how can she cope with this? So she and I tried to work on some activities where she could do some memory making. One of the things I like to do is when we know there's an end of life situation, like talking through with a middle schooler and a teenager, like, what do you want to know about your parent? What questions would you want to ask them? And she was all for that, but their phone calls were brief. She really couldn't get into much and you know, ask him about him or ask him the things that she wanted to know about him. Unfortunately, she was kind of put in between her dad and her mom. The dad would ask questions. Vanessa would try to protect her mom and her mom's privacy. The dad would get upset and start crying, and it was just really hard for Vanessa to just have phone time with her dad and just absorb as much as she could that special time when those other things were going on as well. So there's a lot of ethical dilemmas here, right? If I had to say one, primarily, was Wonders and Worries the best fit for this child? Throughout my time with her, that was always in the back of my mind, right? It's like, is Wonders and Worries the best fit? I did have conversations with mom about transferring her to a more traditional therapist. Definitely one that's used to working with children and teens, one that could focus on all the trauma that she's experienced. And then, of course, going into end of life and bereavement. Yes, at Wonders and Worries, we can provide that support, but she had a lot more going on than I felt was even my role. Yeah. Crystal, thank you. I was about to ask you to go to the next slide. So, you know, autonomy, you know, value who she is, value her ability to cope with all of these situations that she's been presented with. Beneficent, right? Like, is my time with her a benefit to her? Simplistically, I could say yes, but also with the idea that there could be so much more that could have happened. Non-maleficence, you know, no harm. I don't feel that our time together was harmful. I mean, I was able to teach her some skills that cross beyond Wonders and Worries. So, you know, the ability to express herself, the ability to cope with life situations, a chance to, you know, think about her best ability for herself, how to cope, and then add to those skills. So I don't believe there was harm in our time. And then fidelity, right? It's like knowing that she can trust in me, that I'm going to do what I said that I was going to do for her. Each of those continued, and you'll see as I go through, each of those kind of pop up here and there. So, you know, my questions, was our curriculum the best way to meet her needs? I do feel like at Wonders and Worries that medical focus, like that's what we specialize in. So yes, absolutely. I do wish I had more information. That the mom had very little information. We were going with what we knew, but there's parts of it that was left out that I felt like I could be able to express and help Vanessa process what was going on and the reason why. His cancer was abdominal, and she shared with me that she thought he got cancer because he ate spicy food, Takis. So, you know, just being able to have that conversation with her, right? She said she avoided spicy food, but did not give up Takis 100%. So anyway. A sixth grader. She was still a sixth grader. Yeah, that next question, how do I provide medical education with such little support or little information? So, simplistically, I could talk about what is cancer. Why is it now stage 4? What is chemo? What are they doing for your dad? How are they helping him at least stay comfortable? She knew he was bald, so why is he bald? Why is he so tired? Those kinds of things. So. And again, how do I foster a relationship with an 11-year-old with a father who's not available to her? And the phone calls are so short. It was really tricky. Again, looking back, if I could have gotten the social worker at the jail to be more receptive, maybe I could have done something different. I don't know. Or, requested more time. I don't know if they could go against their typical rules, but that would have been nice to at least had the opportunity to talk that through with someone, which I didn't get to do. So my options at the time, do I continue sessions with Wonders and Worries and be that support person to her, be there, process, listen, continue to guide mom. Certainly did that. I did encourage outside support. I gave her some very specific examples of what that could look like. The parameters around someone being able to work with an 11-year-old and trauma. And then who did I consult? So one of the tricky things about not being in a hospital environment is that you don't have that big team, right? So at Wonders and Worries, we're small. We very much support each other. And at that time, my go-to was our program director. So talking things through with her, being able to process what I could offer and what the limitations were. And then, as you can see, the case manager was not successful, unfortunately. So during that time, one of the biggest things that I advocated for was to make sure we had a wrap-up session. You can see those sessions were really spotty over a year, but I strongly, and thankfully it happened, advocated for a wrap-up session so that Vanessa did not have one more adult in her world that did not follow through with what I specifically had told her I would do. So I wanted to make sure that she knew I was available, that it was not goodbye, that I was there as needed. And I just wanted to make sure that she understood that from me, that not all adults leave. Not all adults don't follow through. So I don't know what happened for the client, which is hard, like processing this. That's been a challenge. My guess is that mom did not follow through with outside support. I do know she did not attend the teen group minus that teen social, which was so awesome. And what else? What happened for me? How did I process? I don't think I processed this enough. And Crystal will ask me this question if I don't go there. But processing and getting ready for this presentation really highlighted for me that I've not done enough processing myself. I think a lot of this is secondary trauma. At that time, I really should have done more. I don't see child life specialists enough having their own therapist. I know within the counseling world, the therapy world, it's expected. It's not in child life. So if I can toot anybody's horn, please, child life specialists listening in, and go to your therapist, go to your counselors. Like Sarah says, find your work mom, your work dad, but work on things, talk things through. It's been helpful to reprocess and think about the situation. What would I do differently? Oh gosh, I think I would advocate for more consistency in working with her. Certainly advocating that mom does follow up with a traditional therapist and focus on this trauma. I really think that it needed to happen. And whether I transitioned her to a therapist and the therapist saw that, at the time Vanessa was more focused on the medical, that we could collaborate together and make sure she was getting the support no matter where she was. So, yeah. How does this influence how I practice? Being mindful of my own reaction to life stories, being able to process through that. What's hard for me is knowing that so much more could happen, and parents don't always follow through. It's a hard thing to accept, but I think as practitioners, no matter what our title is, unfortunately, we do have to accept that. We have to know that the work that we've done has been to the best of our ability. I think that's maybe part of my bigger takeaway. I'm so thankful. I really am thankful that I was hopefully the person that I wanted to be for her, that I was an adult that cared, that I was an adult that listened and supported her as best I could, even though there could have been so much more, right? Yeah, being present is really what she needed from me, and I think I was able to give that to her.
Yeah, you did such a beautiful job of sharing that. Thank you, Michelle.
Thank you, Crystal.
And I know that you're right, like there's always more that we see and we want for kids, which just reflects your heart. It just reflects your heart for her, which is beautiful. But most of the time kids don't know what we know. And so there's sometimes beauty in that too, of the fact that like you were a caring and consistent adult for her. You were somebody that she could open up to. And she may not have experienced that anywhere else except with you. And so what you did offer her likely felt like gold in all the trauma that she was experiencing. And so don't discount what you did for her.
Yeah.
It's beautiful.
Sure, absolutely.
I know Missy has a question that came in for
yeah.
you. And then if we have time, then Sarah and I may ask you a couple too.
Okay.
Thanks so much, Michelle, for sharing that. This has been outstanding to hear y'all like share this and be so genuine about as you walk through and process this. But Helen has a comment for you. I wanted you to hear it out loud. This is a great demonstration of the importance of reflection in our practice. Clearly, you played an important role. I would have to agree that an important ethical topic or consideration is recognizing when our interventions with patients and families exceed the demands of our roles, and we should be referring to other professionals. And how do we communicate this to the families we work with?
Mm-hmm. Yeah, absolutely. Thank you for sharing. You know, in my work with this family, it was really like trying to empower the mom and give her some tools. And that's why I really gave her very specific, like go to this organization, being mindful of, cost, or I don't remember insurance. This was too many years ago, but that sometimes families will ask us about that, right? But being mindful of making it as easy as possible in some ways. I mean, she was a busy sixth grader, but trying to find something that was more accessible to them. They traveled to see me. Austin traffic is not always that pleasant. So trying to find something for them that was even closer in proximity to where they lived. So yeah, trying to help as best I could. And then it was in mom's court, right, so to speak, like she would have needed to follow through.
You know, Michelle, when you were talking, it seemed like a particularly painful part for you was the fact that she showed up to the jail and then she couldn't go in. I'm curious for you of, do you think there was value, like all the pre-work that you did of prepping and even the drive there, do you think that there was value for her when we think about grief in the part that did happen, even though she couldn't know?
Yeah, I think like, you know, thinking back at too many years ago to like do a specific, but I think like having the opportunity to focus on her relationship with her dad and memories went really far. I do know that we did a memory box, and as I alluded to, the book about her dad did not come to fruition, but after the loss, when we created the box together, we put in there stories. things that she remembered about her dad. So, you know, in that sense, like fostering the relationship and what she remembered about her father, I think was helpful. I do think in some ways the work that I did related to body changes and the reasons why, I think in a sense would have helped her if she were able to see him in person and have a conversation with him. But because she saw him at the actual funeral, she had a sense that how different he really was going to look. So yeah, absolutely. And trying to guide mom too in helping prepare Vanessa for what could happen. Also recognizing how unusual it is to even go and visit a jail, to be so young. And, you know, so we did talk about safety, that trying to help her understand that, you know, mom is there with you. Of course, this didn't come to fruition, but talking about safety and being put in that position and knowing that we don't know what these people have done, but they're guards and that they're locked doors and that type of thing too. So I'd like to say yes. There could be more, but can I just say yes?
Yes, you can.
Yes.
I mean, I wanted to say yes for you, but
thank you.
You answered it so beautifully. Yeah.
Thank you.
Well, and even just you processing through safety with her, like given the fact that so many of her friends were not being safe, like what that's awesome. So.
You know what I forgot to mention earlier is that she did have a friend whose father was in jail, and they were able to talk through this. So hopefully that was another layer of support for her. Yeah, I meant to share that earlier in the beginnings of her story.
You had a lot to cover. This is a complicated case.
It's a lot. Yeah. One other thing I want to just throw in there real quick, and I know we're out of time, was that, you know, over that year, even after the death of her father, and this is why it was a big question for me, a lot of her processing was about her friends, and our time together was less focused on dad. And it was probably about 5 months in that after his death that we did start focusing on more of that processing about her father. So that was another great big question mark. Is this my role right now? Am I doing enough for her? So yeah. Woo. I'm gonna need self-care after this, y'all.
I was gonna say, I think you've earned the rest of the day off.
What can I do?
You need to move. I think
I know. I'm gonna go work in my garden. Despite the heat, I love that. It's very productive, and it's like immediate reward.
Go hack at some weeds.
Thanks so much.
Rachel, do you think you can speak? Oh, go ahead.
I was just saying, we covered, you know, death and dying and suicidality and incarceration. And if we, you know, are practicing within our role, and even the way that we provide an intervention. I mean, this is just in 3 cases. There's so many ethical dilemmas pop up, I think, daily. So I am really glad that we talked about all this stuff.
Yes, and I so appreciate all 3 of you, Sarah, Michelle, Crystal. This was fantastic to me, and I really appreciated the questions that you all talked through, and really the dynamic between you guys sharing. I really like that. I'll be anxious from our listeners to hear about how that format was for you, because I can see, I know you probably got a little teaser of a couple slides that Crystal went through that we did not cover today. We had those as backups. About processing hot topics and hearing from different perspectives. And I think that it's so valuable for us to talk like this. And so we're going to save those. Don't worry, those slides will show up somewhere at some point, but please make sure you give us your feedback about this presentation. But again, thank you all so much. I appreciate all 3 of you and your perspectives and sharing sort of openly and honestly with all of us today. Thank you for you guys out there listening to us. If you see the QR code there, you can hit that one to get, if you need to take the post-assessment for PDU credit. Our next webinar, I think if you've listened to me before, we've transitioned now to an every other month model of WonderChats at an hour and a half. So our next one will be on October 15th. We're processing and massaging a little bit what that topic is going to be. So you will see my Tuesday tip email that comes out the first Tuesday of each month if you're on our mailing list. Otherwise, go to our website and you can join that. And you will, hear what our topic will be for the 15th, and I hope you'll join us. Enjoy the rest of your day, everyone, and thank you for being here.